Welcome everybody. This is Judy Burleson at ACR. Thanks for all you stalwart folks for joining us on late Friday afternoon. I hope this will be a really exciting webinar to keep you awake today. So I have a lot to cover, so I'm going to go rather quickly in order to allow enough time for questions at the end. Right now everyone is in mute mode. If you have questions, you can put it in chat or raise your hand. So today our topic is looking where we've been at PQRS and moving towards MIPS in the transition to the MACRA program. What we're going to look at is just really quickly the reporting requirements in quality programs before MACRA, a little about the MACRA legislation and the new quality payment programs, trying to understand MIPS and APMs, we'll describe what those are, and ACR resources that are available to help you through these. Currently, there are a number of CMS value-based programs in place before the move to MACRA. PQRS, which has been in place since 2007, the value-based payment modifier, and the EHR incentive program or meaningful use. Really quickly looking at the most recent experience report from CMS on PQRS, from 2013 to 2014, reporting increased substantially by 28%, and that was probably primarily due to the recognition that with those reporting years that penalties were in place. And encouragingly, radiology was the 5th highest reporting specialty in 2014 at 69, almost 70% of eligible radiologists that could participate did. That was the last year for a bonus under PQRS and the second where a penalty would be in place. And looking at those EPs or eligible professionals that avoided the penalty, which was a good bit more than half, 83% of those that were penalized were so because they did not participate at all in PQRS. Looking at the payment adjustments that have been in place with the current quality programs, and particularly looking at 2018, which is the payment year for the current performance year of 2016, the penalty amounts adding up across PQRS and the value modifier and meaningful use could be a potential negative 10% cut on Medicare reimbursements. And so just refreshing our memory that for the payment adjustment year is 2 years after the performance year. So again, 2016, the payment adjustment year is 2018. So what is MACRA exactly? The Medicare Access and CHIP Reauthorization Act. That is an acronym within an acronym. And primarily, MACRA ended the sustainable growth rate. That was a formula that determined Medicare payments for services provided to beneficiaries. And MACRA has built a new framework for rewarding providers for giving better care, not just more, so value versus volume. The CMS is implementing MACRA as the quality payment program and combining existing quality reporting programs that we just talked about into one new system with 2 pathways, including the alternative payment models, which is the second pathway in the quality payment program. So these are the 2 pathways, the merit-based incentive payment system, now becoming lovingly known as MIPS, and alternative payment models, advanced models, or APMs. What is the time frame for MACRA? The MACRA legislation sunsetted the current quality programs to end in 2018. and for the new structure to begin in 2019. Looking at the associated payment adjustments under the MIPS pathway, there's a range of possible adjustments, positive and negative, from 4 to 9% in later years. And with the alternative payment models, that there's a across the board 5% bonus, and those eligible clinicians would be excluded from MIPS. So I'm going to first look at the advanced alternative payment models. One reason, because they tend to be discussed later in overviews of the quality payment program. So I'm going to give them first billing, but also because I want to spend more time on the MIPS pathway, because that is where most clinicians will fall. Exactly what is an APM? CMS has defined it as really innovative ways to pay for care, and incentivizing quality and value over volume. And in the legislation, certain alternative payment models were identified as being qualifying to exempt clinicians from the MIPS pathway, such as the Innovation Center models, Medicare Shared Savings, and several demonstration programs. For the most part, the criteria that needs to be met for clinicians in a qualified APM is that the APM bears significant financial risk, and that quality measures comparable to those in the MIPS program are reported by the alternative payment model entity, and that they use certified EHR technology. So clinicians that are in qualified APMs would be exempt from MIPS payment adjustments and would qualify for the 5% incentive payment. So looking at the what APMs may be qualifying, they are those that bear more than a nominal risk for monetary losses. So as you can see, this is a busy screen, but you can see that there are 6 models, currently 5, actually currently 4 in place that have been proposed in the rulemaking process by CMS. The Medicare Shared Savings Tracks 2 and 3, but it does not include Track 1 ACOs, certified medical homes, or bundled payment programs, so only upside and not upside risk only models. So what this is telling us is that most clinicians will be subject to MIPS and not in APMs. However, there is a hybrid where eligible clinicians that participate in alternative payment models, but those that are not meeting specifically the requirements of advanced APMs, they do get some scoring benefit in MIPS. So let's move to MIPS now. And let's go back again at looking at the year, adjustment year and the performance year. So right now we are 2016 in PQRS, value modifier, and meaningful use, and looking at 2018 as the adjustment year for this performance year. So in knowing that MIPS is supposed to start and the quality payment programs is supposed to start in 2019 in terms of payment adjustments, that means that the performance year is 2017, so next year. The quality payment program streamlines the current quality programs into MIPS, so the PQRS program, value modifier, and the meaningful use program, and adds a 4th component, clinical practice improvement activities. Who is eligible to participate in MIPS? For the most part, MIPS eligible clinicians are those that are eligible for PQRS. CMS is implementing the MIPS with requiring physicians, PAs, nurse practitioners, and those other clinicians that you see here as being eligible in year 1 of MIPS. That these clinicians can participate both as individuals or as groups. Who does not participate in MIPS? So there are some exemptions. Those clinicians who are in their first year of participation with Medicare, low patient volume providers, and participants in advanced alternative payment models that we just talked about briefly. So there are 4 components of MIPS, as I mentioned: the quality, which is based on the structure of PQRS; resource use, which is basically the current cost component of the value modifier; the new category, clinical practice improvement activities; and a 4th, advancing care information, which is similar to the meaningful use program. Let's look quickly at the elements of each of these 4 components. I'm going to go through these rather quickly. There's a lot to learn for all of us about the MIPS program, and we will, the ACR will be rolling out a number of educational modules and materials and presentation and webinars to go into more detail onto each of these components and other aspects of the quality payment programs. But for now, let's just get a general idea about the requirements. In quality, there has been, the changes from the current PQRS program is reducing the number of measures required from 9 to 6 and doing away with the National Quality Strategy domain requirement. There continues to be the requirement for 1 cross-cutting measure and 1 outcome measure or other high priority measures if outcome measures are unavailable. The measures that clinicians would select from have been proposed pretty much the same as the measures that are in PQRS program now, whether they're PQRS measures or registry non-PQRS measures. Those will be called MIPS measures and non-MIPS measures. There will be 3 claims-based measures that CMS will calculate. These measures will likely not apply to most radiology groups. So in looking at how the program, the quality part of the quality payment program is scored, it has the heaviest weight in the composite score of the program at 50% in 2019. I'll go into that a little bit more later. The resource use component, these are claims-based calculated measures. It does not require reporting. The changes from the current program and the value modifier is that CMS is removing several of the measures and keeping only the total per capita cost measure and the Medicare spending per beneficiary measure, and will add over 40 or more episode-based resource use measures to the program. And keeping in mind that for most radiology groups, if you're familiar with the cost component of the value modifier, that the claims measures, and we suspect most of the episode measures, will not be applicable to radiology groups. The clinical practice improvement activities, the new category, is for the most part similar to what you might do under Maintenance of Certification Part 4 for board certification. There are 8 activity categories. CMS has identified over 90 activities within these categories. You don't need to do activities in each category. The categories are expanded practice access, population management, care coordination, beneficiary engagement, patient safety, and integrated behavioral and mental health. So the requirements for the CPIA category are to the maximum points are 60, where you would do high or medium weighted activities and earn points depending on the weight of the activity. Full credit is 60 points for most eligible clinicians, and the participants in APMs would get credit for that, full credit for that. In the first year, 2019, the weight for CPIA is 15%, and I forgot to say the weight for resource use is 10% proposed. So the fourth category, advancing care information, similar to the meaningful use program, is somewhat different in that in the proposals that CMS has put out, that it is no longer a pass-fail program as the meaningful use program was. It's replaced with base and performance scoring. The number of required measures are reduced, performance score thresholds are eliminated, and the public health registry reporting requirement has been reduced. The proposed weight for advancing care information in the composite score for MIPS is 25%. So these 6 areas are the categories for the base scoring in the advancing care information. The performance score, which provides for additional points, are these 3 categories. There are a number of concerns and questions about the advancing care information as proposed in the rule that came out in April-May timeframe, where there have been questions on how the exclusions have been dropped from certain measures, and what it means to some of the measures have just, they remain and they're unchanged. They're simply just reorganized. The exclusions, such as the PQRS exclusion, the specialty exclusion for radiologists, was also eliminated. So there were a number of questions surrounding this component. So how is MACRA and QPP going to affect clinicians? As I was alluding to, the overall for the quality payment program, the 4 performance categories each are weighted differently. In 2019, the quality is most heavily weighted at 50%, and advancing care information at 25 is the highest weight in the total scoring. And this is a little bit hard to see, but just give you a general idea of how the scoring is done per category. There's different methods for calculating the category score and then applying the weight to that score to come up with the overall composite performance score. So the way that adjustments are determined is where the eligible clinician or group is on the continuum from 0 to 100, performance threshold being in mid-range, so that is where a 0 adjustment would apply. Doing better in the composite score would result in bonus. Now let's talk about this term that's being thrown around, non-patient facing. This is kind of controversial in the connotations that it brings forward about non-patient facing and how radiologists may be so separate from the patient care. So the AACR has, in its comments to CMS, provided suggestions and recommendations for revising that term. But on the other hand, the non-patient facing allowance in the MACRA legislation makes it somewhat easier and less burdensome for clinicians considered to be non-patient facing to be successful in the program. So what exactly does that mean? CMS defined non-patient facing as clinicians and groups that bill 25 or fewer patient-facing encounters during a performance period, whether as an individual or a group. And describing that patient-facing encounters are general office visits, outpatient visits, and certain surgical procedure codes. The unfortunate piece is that with the rule, CMS did not provide a list of patient-facing codes, so that we're really not sure what that means for certain groups, in particular interventional radiologists and groups that are hybrid that have both diagnostic and interventional radiology services. And thinking about how CMS proposed this as 25 or fewer encounters, that seems to be, particularly at the group level, very low threshold for determining non-patient facing, and brings about a good number of questions. But let's look at what the differences are in the total performance scoring for patient-facing versus non-patient-facing professionals. So the four categories: quality, cost, advancing care information, and CPIA. Patient-facing professionals are required to be involved in each of those categories and would be scored for that. If you look at the non-patient facing determined individual or group, then you take away the two in the middle, cost and advancing care information. Those are the most difficult categories for radiologists and other non-patient facing professionals to be able to successfully meet requirements. And that was recognized by Congress in the legislation and by CMS. So they are trying to make allowances for that. So then that leaves both just the quality and the CPIA activities. And so there will be some benefit to the having those two middle categories removed. If you look at the clinical practice improvement activity category itself, patient-facing clinicians will be required to have 100% compliance. They must gather 60 points across a number of activities. For non-patient facing and also for rural clinicians, the requirement is only 2 activities, and all activities are weighted the same level, so there's no high or medium value. All are weighted to 30 points. So the requirement for radiologists determined to be non-patient facing would be 2 activities under the CPIA. So if we look again at the performance category weighting for MIPS, 50 at quality and clinical practice improvement at 15. If you remove the resource use and advancing care information, CMS proposed several ways to reweight to categories if for non-patient facing and other professionals where the resource use and advancing care information are no longer applicable. So potentially the 2 remaining categories, CPIA and quality, would be reweighted equally, so that from the 25% of advancing care information and 10% for resource use, that would be split and added to each of the 2 remaining categories to give CPIA 33% and quality 67%. Or it could also be reweighted completely to quality and leave CPIA at 15% and then have a greater emphasis on quality at 85%. Either way, it's tricky business determining, one, what's non-patient facing, the mix of your group, whether it's interventional and diagnostic only, and figuring out what exactly that means for your group and what you will need to do. We just don't know at this point in time. But regardless, focusing on the quality, particularly the quality category and the CPIA categories, is what radiologists most likely will need to do. And looking at the MIPS timeline for the first couple of years as proposed in this summer's rule, initially CMS has proposed starting the quality payment programs January 1st, 2017. That's 20 weeks from now. That doesn't give us a lot of time to figure out The final rule on the QPP is out probably in October timeframe, so that just does not give a lot of time for preparation. So with that and a number of other issues and concerns that were spelled, that the proposed rule did bring about, like many other organizations and specialty societies, ACR poured through the rule and made recommendations to CMS for modifications and changes to the proposed rule, or to the final rule. This was led by the newly created ACR MACRA committee, led by Dr. Greg Nicola, and a lot was put into providing recommendations to CMS on changes. Won't go through all those now. Our letter is available on the ACR website if you want to take a look at it, but key provisions of those changes are really encouraging, strongly delaying the start date of MIPS until at least July the 1st of next year, and having an initial reporting period for just 6 months of the year, to make changes to the advancing care information category to where it's more, in some ways more similar to the meaningful use program, to allow exemptions and null value for certain measures, modify the term non-patient facing, and particularly for the non-patient facing determination to have at least a minimum threshold of 100 encounters for non-patient facing consideration. Also looking at our recommendation was to reweight the points for ACI and resource use evenly across the quality and CPIA categories. Another key issue with the proposed rule is that CMS is suggesting that the reporting rate for pretty much every mechanism would increase from 50% to 80% for claims and 90% for other mechanisms, which is really a substantial increase in a short period of time. We also made recommendations about automatic credit for QCDR reporting in the CPIA category, and that APM criteria should be broader. We are continually putting together resources to help you be ready. There's a new page on the ACR website dedicated to resources for learning about MACRA and the quality payment programs. And this is a screenshot of it and the link for it. I wanted to go quickly again through the data submission options by category, just to give you an idea and you can see it here on your screen, for both individual and group reporting, how you submit data. For quality, the existing methods are maintained, including claims-based reporting for individuals. Resource use continues to be only through administrative claims. For the advancing care information, CMS is proposing, at least in the first few years, attestation only, and that could be done through a QCDR, qualified registry, and potentially through actual codes on claims. The same is true for submitting data on the clinical practice improvement activity category, which is at least initially indicating yes or no for each of the 90+ activities in CMS proposed inventory. So the current programs that the ACR has that we are working towards helping you transition to MIPS. I think many of you on the call have been involved in our registries in the QCDR, and so we're familiar with that, that we're encouraging radiologists and groups to look at that as a potential means for helping you be successful under MIPS. The Radiology Support Communication and Alignment Network, known as RSCAN, is our program which is funded by a grant received by the CMS Innovation Center. This is a proposed activity in the clinical practice improvement activity category for which you would be able to earn credits. And our Imaging 3.0 initiative can really support groups in looking to be involved in activities that may be approved for CPIA activities and transitioning their practice to different or alternative models. I did want to say also that we will enhance the QCDR in 2017 in a number of ways, but also intend to have functionality to report CPIA and ACI for our participants. Just briefly, what is a QCDR for those on the call that may not be aware? That's a program or a reporting mechanism that was approved for PQRS participation starting in 2014. The ACR's registries have been approved since then, since 2014, and continue to be so for 2016. And it's the Qualified Clinical Data Registry is basically a clinical data registry that was initiated for quality improvement purposes, and it's somewhat different from the other type of registry in the PQRS program, Qualified Registry, as the QCDRs can report measures that are not traditional PQRS measures or will be traditional MIPS measures, but can report measures from the registry's measure set. And here is a screenshot of our web page. Give you a link to the QCDR if you would like more information. Some benefits are that, one, it supports both individual and physician group practices, and using the combination of PQRS or non-PQRS measures, you can meet requirements for the PQRS or MIPS program, and will be able to report the three categories under the MIPS program that I mentioned. Importantly, the registry will give feedback to participants at least quarterly so that you can review your performance scores throughout the year and improve as appropriate to increase your performance scoring and chances for success in PQRS or MIPS. Here is a link to resources on our QCDR. And a little more information about the RSCAN network. As I said, it was funded by the CMS Transforming Clinical Practice Initiative. The ACR is one of 10 national organizations that were awarded such a grant, along with 29 other organizations known as Practice Transformation Networks in the TCPI program. And the idea of RSCAN is to promote patient care, encouraging radiologists to work with their referring clinicians to build relationships and provide education and interaction on selecting most appropriate imaging. It is an opportunity to show CMS how radiologists can provide value to patient care. The program incorporates currently 11 Choosing Wisely imaging topics as the basis for the program, and integrates the use of the ACR Select Clinical Decision Support Tool, web-based portal at no cost to RSCAN participants. The RSCAN can help your group and your referring clinicians get used to clinical decision support before it is implemented under the Protecting Access to Medicare Act. And as I said earlier, earn points under the MIPS CPIA performance category. It also offers MOC Part 4 credit and some CME activities. So to start wrapping up, some takeaway points that MACRA changes substantially how Medicare pays clinicians and pushing forward more effort towards providing high-value care. It's time now to familiarize yourselves with the MIPS program, the quality payment programs, which you are due by virtue of attending this. As proposed right now, January 1st is the start date of the quality payment programs, which isn't a lot of time. So we encourage you to take a look at the resources that ACR provides. We'll continue to provide materials and resources on our website in various channels, and encourage you to ask us questions. And just to give you a reminder, some current events occurring relatively soon. Our annual quality conference in Boston, September 16th and 17th. That's a great opportunity to learn about quality measurement, quality improvement, formal improvement science, to meet with your colleagues and learn from each other. Then we've scheduled tentatively a webinar in September on submitting data to our QCDR accurately, and encourage you to keep a lookout on all our communication channels for educational modules across the college, provided by both staff and your colleagues in radiology. So that's about it. The contact information, and we can open the line for questions or ask ones from the.
We don't have any questions right now. We've answered several on the chat so far, so everybody should be able to see our answers for those. One of the questions was about physician assistants and nurse practitioners. Are they considered EPs in the first year? I believe they are.
Yes, that's true. If you have a question, you can raise your hand and we can unmute your line.
Okay, we just got one from Maria Calamaro. She's asking, is RScan participation all or nothing for credit for CPIA? In other words, does RScan have a host of requirements for radiologists to participate? And can they start with some or slowly and advance over time, yet still receive credit for CPIA?
Thanks for the question, Maria. That goes back to the requirement for the category itself. So one of the activities that CMS identified was participation in the Transforming Clinical Practice Initiative. So if you're participating in RScan, you're participating in the TCPI program. And the requirement under CPIA is proposed is that you participate in the activity for at least 90 days during the performance year. So participating is kind of a nebulous description, but if you're involved, enrolled, beginning to do some work on one or more of the topics, and whether that's for the group or the individual, that is also a question that is not quite clear in the proposed rule, how CMS determines group under the CPIA activity. But if an individual in your practice is involved to some extent in RScan, then they should receive credit for that as a CPIA.
Thank you. The next question is from Mark Canada. Is it too early to register for 2017 NRDR participation?
No, not at all. It's not too early to register for NRDR, and we encourage everybody to do that now. So you wouldn't be able to actually register, you wouldn't be participating as 2017 QCDR. You can register for the for NearDear, for any of the databases, and start to get the processes going, get your facilities enrolled and data being submitted to us, start looking at your feedback reports and getting a good sense of that. So it's never too early to do that. It's not going to actually count towards 2017 reporting per se, but it will help you.
Okay. Next question's from Steve Mathis. How does using teleradiology impact PQRS and MIPS? Are those studies read by another group providing teleradiology included in the registry reporting?
I would say if you are billing for those services under your tax ID number with that individual radiologist or group in the telehealth group, then you should include those.
Next question from Colby Jensen. Has there been any word on how to deal with the EHR problem? Most radiologists are interventional or diagnostic, and so they will meet the face-to-face thresholds. This could be a large participation problem within MIPS. As well, most ACOs are Track 1 and do not qualify for CMS's description of advanced APM, inclusive of EHRs. You're right.
The EHR, the Advancing Care Information category, is problematic the way that it has been proposed. And as you're saying, that it's likely that as proposed for the non-patient facing determination, many radiology groups would still be considered patient-facing, and so need to do the Advancing Care Information category. So there was, as I alluded to in the ACR's comments to CMS about the proposals for ACI and how they've designed it, there's a lot of problems with it. We weren't alone in those concerns across the organized medicine. There's been a good amount of concern about how it's being rolled out, and hopefully there will be some changes to that, but we'll just have to see how it's modified.
Okay, next question is, can you review the resource use value modifier calculation specifically? How is this calculated exactly, and how is radiology possibly exempt from this calculation?
So the way that you can get an idea of what that is, you may have already looked at your quality resource use reports, the QRURs that are available on an annual basis, and they look at the QRURs provide information on your performance scores under PQRS. That's the quality element of the value modifier, and also the cost measures. So currently in the value modifier program, there are the total cost of care overall measure and total cost of care for 4 chronic conditions like asthma, heart failure. And then the 5th measure is Medicare spending per beneficiary. So the way that those total cost of care measures are calculated and attributed is primarily based on plurality of primary care services to a beneficiary. So for 90-something% of radiology groups, those cost of care measures wouldn't be attributable to your group because the plurality of care just wouldn't fall through that way. The Medicare spending per beneficiary measure may be attributed to groups because that looks at an inpatient admission, and whichever group provided the majority of services in terms of dollars for a patient during the hospital admission, and then looks at the cost 3 days prior and 30 days after. And so that is really currently the only measure in the value modifier cost component that might be attributed to radiology groups. So if you look at your QRUR report, the 2014 report should be out in like the next month or so, then that will give you some sense of how your group might be affected under the cost component for PQRS and value modifier, and potentially under MIPS. But if your group is determined to be non-patient facing, then that you would just be exempt from that category. That's a lot. I don't know if that was helpful or not.
Next question is a quick one. What constitutes a group for reporting purposes? Is it 10 or something else?
It is 10, tax ID number, 2 or more individuals under a 10. And you're a group as a 10, but to be a formal group for PQRS participation or the group practice reporting option, GPRO group, you have to register with CMS to be a GPRO. That traditionally has been through June of the performance year. So if you wanted to be a GPRO for 2016 PQRS, you would have had to register by June 30th. The details of how that will work under MIPS aren't quite clear, but it should be very similar to PQRS.
And so far we've only got one more question. When CMS is calculating total number of office visits, are they only counting those billed to CMS or all, i.e. commercial payers as well?
Oh, that's a good question. I believe it's Medicare, but I'll have to check on that to make sure. I'm pretty sure it's Medicare only.
You can send us your email address, Doris, and we'll look into that and then get back to you. Although Maria just chimed in and said it is Medicare only.
Thank you,
so
Maria.
Sounds like it might just be Medicare. And that's all we have right now. If anybody wants to raise their hand or ask a question really quick, we can take it.
Yep. Well, if not, or while you're thinking, again, thank you very much for attending and sticking with us this late hour on a Friday afternoon. I know everybody's probably looking forward to the weekend. So just continue to reach out to us, keep abreast of the educational resources that we provide, ask us questions, give us feedback, let us help you. And thanks for attending.
Okay, I think that's it. We don't have any more questions.
Okay, thank you.
Thanks a lot, everybody.